So today I'm going to talk about music and aging, but what I want to do first, while I have your attention, is actually thank the people who helped me do this work. Usually people save this to the end, I want to do it first. There's 4 people in there, Dr. Emily Bolt, Dr. David Fleming, Dr. Sarah Sauve, and Dr. Marie-Hélène Langlois, all contributed greatly to the work I'm going to present today, and I want to thank them immensely for the help they did. Auditory aging. So hearing loss in aging is pretty much the most common health issue reported by older adults. It's actually really rare to find an older adult that doesn't report some issue with their hearing. Now that doesn't always reach clinical significance, but most older adults report, yeah, my hearing's not quite as good as it was when I was in my 20s. Things are not as good as they used to be. And in fact, in the hearing science community, the very few people that show absolutely no age-related change we call them golden ears, and they're so rare to find an older adult who shows absolutely no signs of age-related hearing loss. Now, in terms of the medical community, auditory aging is not a huge priority. It's not cancer. You're not going to die from hearing loss. But loss of hearing abilities can lead to things like social isolation. Can't talk to people, can't carry on a conversation. That can lead to things like depression. More importantly, there's emerging research that suggests it might actually predict cognitive decline. And they did a really neat study a few years ago where they measured people's hearing, people around my age in their sort of 40s and 50s. And everybody had normal hearing, but some people were slightly worse than the average, than what would be expected. They then tested them about 15 or 20 years later. The people who had totally normal hearing in middle age, about 1% of them experienced cognitive decline when they were in their 70s. The people that had very mild, almost not clinically relevant, but very mild, 30% had cognitive decline so being able to improve hearing abilities could have these cascading benefits, would reduce social isolation, reduce depression, potentially mitigate cognitive decline. And so that's the sort of overall goal of my research. Now to start my talk, I want to start to talk about what age-related hearing loss and what auditory aging is and what I'm going to talk about. So what I have a picture on here is the ear. When we hear, sound comes through our ear, goes through the eardrum, or ear canal to the eardrum. It moves these 3 small little ossicles in the middle ear, and eventually the sound wave is pushed into the cochlea, which is a fluid-filled structure where transduction occurs. And transduction is the process by which we turn a physical stimulus, so sound, or also light, or touch on your skin, or chemicals in the environment, into a neural code that your brain can understand. And the way the auditory system does that is with these little hairs. They're microscopic, they're called stereocilia, and they look like that. When sound comes in, they basically shear back and forth and send a signal to the brain of the sound that you're hearing. And we can measure how well these hairs are functioning using a test called pure tone audiometry. And anybody in the room who's been to an audiologist has probably done this test. The graph you're looking at on the bottom, you'll see frequency. So this maps different pitches or tones that you can hear. And this on the side maps basically the quietest sound you can hear. So in this case, lower scores are better. So that's why the graph is plotted upside down. When we look at this graph, you see younger adults have sort of thresholds around 0 decibels. Older adults show elevated thresholds and much more loss at higher frequencies. And this is due to changes in the hair cells and the structures that support them. Oh, and that's what the test sounds like. You'd hear a beep of a frequency, and it gets quieter and quieter until you can't hear it anymore. And that's how you would measure those thresholds. You do that for different ears and different frequencies. But there's another aspect to hearing loss that is not talked about as much and what I'm going to focus most of the talk on today, and that's at the central level. So if you think about sitting, maybe not in today's environment, but sitting at a noisy cafe or a coffee shop, all the sound is reaching your ear at the same time, and it's your brain that has to figure out what sound goes to your friend's voice, what sound goes to the band playing, what sound is the cars driving outside. So this neural processing is of critical importance as auditory information ascends into the brain. And emerging evidence suggests that this part of hearing is also disrupted with age. And we think that it's due to changes in neural timing. So this is how well neurons are firing and how well they're synchronized with each other. And timing is really important in the auditory system. And my quick example is imagine how we locate sounds in space. And one of the ways we do that is by our 2 ears comparing the arrival time of sounds. So if a sound is directly in front of me, the sound will arrive at my 2 ears simultaneously. If I move about 45 degrees off center, the sound's going to arrive at this ear slightly before this ear, on the order of microseconds. So if neural timing is disrupted on the order of microseconds, suddenly you can't organize where sounds are coming from. So even small changes to neural timing are going to have a big impact on how well you can hear. And this leads to difficulties with discriminating frequencies, locating sounds, discriminating how long sounds are, detecting silent gaps, detecting mistuned harmonics. These are all things we do in the lab. And the important thing is that performance on these tasks that require you to make a judgment about the sound is often not related to those pure tone thresholds, suggesting that there's two independent pathways of decline. Obviously, if you lose your hair cells and are getting a bad signal in, there's going to be some impact on how the brain can process that sound, but they're both declining, can decline separately. So my research is focused on using this idea of neuroplasticity, that the brain can be changed based on our experiences. And the question is, because so much brain processing is important for listening and understanding, maybe we can improve hearing. We can improve hearing by improving how the brain processes acoustic information. And I'm going to take you down two different lines of research, and hopefully they will come back at the end of the talk a little bit. First, I'm going to talk about some work I've done on using music training to improve hearing abilities in older adults. And second, I'm going to talk about the impact of aging on music perception tasks. And hopefully we'll tie that all in at the end. So I'm going to start talking about music training and the ability to understand speech in noisy environments. So, as I said before, understanding speech and noise, when there's lots of people talking at a bar, or a coffee shop, outside, is a brain process. And if you ask most older adults, again, what their biggest hearing issue is, it's not hearing people in this kind of environment where I'm the only one talking, there's very little background noise. It's understanding people when there's lots of background noise. So we want to see if we can improve that ability, because that's the main problem reported by most older adults. So the first study I'm going to talk about is a study where we took a fairly large sample of people, about 160 people. About half were musicians, half were non-musicians, and first we looked at their pure tone audiometry. So that's what I plotted up here. So this is the same graph I plotted before. So we have our different frequency threshold, our different frequency bands, and our thresholds. And again, our young adults here are in solid lines, older adults dotted. The musicians in the group are in red, and the non-musicians are in blue. And what we see is, again, our typical effect of age, but importantly, no effect of musicianship in this sample. And what I've done here is just averaged across all of these frequency bands to highlight this declining threshold across as we get older. And again, no effect of musicianship. And what we have here, when we talk about musicianship, the musicians were all people who did a minimum of, I think, 5 or 6 years of formal training and continued to practice at least 10 hours per week. So these are fairly active musicians. Some were professional, some were amateur, but liked to play a lot. And our non-musicians were people who had less than 1 year of music training and never played. So that leaves a whole bunch of people in the middle, but we purposefully selected sort of people from the extremes to highlight any potential differences. So what this finding tells us is that in this sample, the hair cells in the ear, the mechanisms of transduction are about the same in both our musicians and non-musicians. Then we want to look at a test of understanding speech and noise. Tests of speech and noise are fairly simple. We present a sentence. The participant in the study would repeat that sentence back, and then we start adding background noise. It sometimes is white noise. Sometimes it's people talking, like you're at simulating yourself at a bar or a coffee shop. So I'll play you what it sounds like. If you hear the sentence, please shout it back to me. So you can hear a bit of background noise, very quiet, and then
tear a thin sheet from the yellow pad.
Anybody hear that? Anyone repeat it out loud? Great. All right, now we're going to make the background noise louder.
Crouch before you jump or miss the mark.
Anybody hear that one? No? Crouch before you jump or miss the mark. And maybe there's one young person in the audience, it looks like. Maybe they can understand this one. Anybody hear that one? I'm looking at you. Sorry for singling you out. No, the square peg will settle in the round hole. So what we've plotted here this is called decibels SNR. Now, when we call we call that signal to noise ratio. And when we think about speech and noise, we're thinking about speech as being a signal, noise as being the background, and we have a ratio. So 0 means that the speech and the background noise are the same volume. A positive number means the speech is louder. than the background noise. A negative number means the speech is quieter than the background noise, and then as a function of age. So you see there's some variability. We have some older people doing quite well, some sort of middle-aged people doing not very well at all. But generally, if we look across the lifespan, there's this decline in the ability to understand speech and noise. Now, the important question is, what happens when we look at our musicians and non-musicians? We see significantly different rates of decline in those two groups. So much that the average 70-year-old musician is doing this task as well as the average 50-year-old non-musician. So 20 years of benefit in terms of the ability to understand speech and noise. So this is great. Musical training helps hearing. But there's a major problem with this study. And the findings might be meaningless. And why is that? Well, what we're looking at is pre-existing groups. I went out and asked people who are musicians to come to my study, people who are non-musicians to come to my study. Maybe people who become musicians have better hearing to begin with. Maybe people who choose not to become musicians have worse hearing to begin with. And you can imagine, this makes sense. You can imagine a child sitting at the piano. One kid can hear all the mistakes they're making. The teacher says, you're making a mistake, play this note instead, and they hear it, and they like piano, and they go on. Another kid keeps making mistakes. Teacher says, you're making a mistake. I can't hear. I don't know. I don't hear the mistake I'm making, right? So who's more likely to give up playing piano? Probably the kid that doesn't hear their mistakes. So maybe all I've done here is identified people with good hearing and then tested them and then compared them to people with bad hearing. So maybe that's what happened. So the way to solve that problem is to use an intervention study where we take people who don't have musical training, give it to them, and then see if we can improve their hearing. Now, a few people have now done this in children, and it works. Depending on the methods and things like that, it takes a couple of years, but you do start seeing benefits to hearing abilities in children, suggesting that what we're seeing there is at least partially due to the training. It may still be due to some inborn characteristics and predispositions, but there's some effect of training. What I wanted to do is to see if it's ever too late. Can we give music lessons to older people and improve their hearing? So we did a randomized control study design. We took a group of healthy older adults, randomly assigned them to either get music lessons, to play a video game, I'll explain this a little more in a few seconds, or to a no-contact control group. So why a video game? First of all, when I show you the piano training we did, it might make a little more sense. Secondly, if you think about when we're testing drugs, what's an important thing to have is a placebo, right? We want to make sure that it's not just the people who take a pill think they're going to get better and they get better. So we wanted to have something that was complicated, was engaging, and difficult, the same way learning music might be for someone who has never learned music, but we don't expect it to have any benefits to their hearing. And actually, I partnered with a professor at Université de Montréal on this project, and he studies visual spatial processing, so how we process the visual environment, and he has shown a few times now that playing 3D video games like Super Mario 3D can actually improve your visual spatial processing. And so we sort of set it up as the music group was his control, his placebo for his visual spatial tasks, and the video game training was my placebo control for the auditory tasks. So how do we do the study? We did a pre-training assessment, so we had a whole bunch of tests. I'm going to only tell you about a couple of them today. We did 30 hours of practice over 12 weeks, another midterm assessment, another 30 hours of practice over 12 weeks, and then a post-training assessment. This is what our sample looked like. Fairly matched. You'll notice that there's not that many people in the video game group. We did have a lot of withdrawals from the video game group. As it turns out, people in their 60s and 70s weren't too keen on playing Super Mario Brothers for 6 months. But what we learned from what we think about this is very interesting is the people that did choose to stay in it create sort of the last possible cohort to test of people who have never played video games before, because the next cohort of older adults will have grown up on Nintendo and Atari and things like that. So it was really, this was our last chance to test a group of adults that had never really played video games. So it was a real, last sort of chance opportunity. The music training we did, again, we wanted something that was easy, self-directed, could be fun, and could be done relatively inexpensively. So we set them up with a piece of software that kind of gamifies learning piano. It's kind of like Guitar Hero or Rock Band. It's called Synthesia, and basically the way it works is, if you can see on the screen behind me, there's like an image of a piano on the screen. It's very faint, and colored bars will come down, and as they cross the keyboard, they tell her which note to play and when to play it. There's also a metronome click that helps with timing. Lesson 1 was just tapping middle C in time to a metronome, and then tapping C below middle C in time to a metronome. I thought this would be trivially easy. As it turns out, for people who've never touched a piano before, it's not easy at all. So here's her very first time touching a piano. So we came back 6 months later, and many of our participants loved this. I helped a few people go buy pianos afterwards. They wanted to keep the software. They had a great time. A couple of our participants hated it, just so for balance and fairness, but many of the participants loved it. Most of them did, and most of them improved significantly. So again, 6 months of self-directed piano lessons. We're not making great musicians here. We're barely even going to be able to play a song, but I think she improved dramatically. She did this all herself. So in addition to like those we had exercises, scale exercises, but we also wanted it to be fun. So we let them work on songs as well, and they could pick the songs that they wanted to learn. And so here she is 6 months later.
Parfait.
Okay.
So a big improvement. And she had fun, she had a good time doing it, so that's great. Now, and I think that's hugely beneficial to her. My interest is, did it improve her hearing abilities? So we did 2 tasks to look at. One is how they could understand speech and background noise, and then 2, to try and figure out what the brain was doing and how the brain changed as a function of this music training while doing a speech and noise task. So the first one we did looked at EEG. And I'm going to give a very quick explanation of what EEG is. So our brain is made up of billions of neurons, and they're all oriented in parallel to each other, and they sort of go around the sulci and gyri in your brain, but they stay parallel to each other. And they communicate with electricity. And when bundles of neurons fire together, it indicates that they're processing something, and they produce an electrical field that we can measure at the surface of the scalp. That's what EEG is we're just measuring the ongoing oscillations of neurons in your brain, and we're measuring it at the scalp. So this is what it would look like. We put these electrodes on the person's head. They're filled with a little gel to increase conductivity, so we can measure the brain waves. And the brain waves look kind of like this. It's just an ongoing sort of noisy signal. Now, we want to look at how they're processing speech and noise. So we're going to present a sound, we're going to present speech sounds to them and measure their brain response. But how are you going to see the response to a speech sound in this sort of mess of waves? And one way we do it is called something the event-related potential technique. So if I present a word to you, your brain is processing that word, but your brain's doing a lot of other stuff too. Your brain is, keeping your heart beating, breathing. Maybe you're also thinking about like what you're going to do later today, all this other stuff. So there's noise. But the neat thing is that if I present a word to you, if I present the same word to you multiple times, the brain processing of that word is going to be about the same each time, whereas that other stuff is going to be random. So if we average a whole bunch of trials together, we get the brain response to the word while the noise gets reduced to almost nothing. And that gives us something called an event-related potential. It's a brain potential related to some event in the environment. In this case, presenting a word, but we can do it other ways. We could flash a light, we could touch their skin, they could move their finger, any sort of event. But in this case, we're presenting sounds. We can then plot that over the surface of the scalp and see where on the scalp this certain activities are coming from. So, knowing that sort of very brief introduction to EEG, the task we had people do was a word and noise task. So we basically presented people a word and they had to repeat it aloud. So very simple. But in some of the conditions, there was background noise. So I'm going to play you what they heard, and after each word, they would repeat that word aloud. This work was done in Montreal, so all the stimuli you're going to hear for this study are in French. So don't be alarmed if you don't understand anything.
Ça vous dirait Sœur, sport, rythme, pleine.
So that's all. So that's the stimuli. They heard that. We record their brain responses to each word. And we had 2 tasks, one where they repeat the word aloud. We did a passive task too. I'm not going to get too much into this. We sometimes include passive tasks with EEG because your brain often has 2 stages of processing. One is sort of this obligatory, like your brain will respond automatically to stimuli in the environment. But if you're not attending to it, the sort of attentive processing doesn't occur. So it allows us to separate what happens automatically versus what happens more intentionally in terms of your listening. Now, in terms of results, so what did we do? First, this is a big complicated graph, so let's look at it. First, we have words correct. So this is just accuracy. So up is good. On the bottom, we have our three groups. There's the music group, the video game group, the no contact group. Then we have our three noise levels. So there's the no noise condition, quiet noise, loud noise for all three groups. And the colors represent when in the training they happened. So blue is pre, green is mid, and red is post. The first thing you'll see is that it's trivially easy to repeat a word with no background noise. And even with a little bit of background noise, performance is way above 90%. So we're not going to see any improvement in these areas because you can't improve beyond 100% of the task, or much above it. So the question is, what happened in the loud task? In the music group, we saw a statistically significant improvement in the number of words repeated. They went from about 69% of the words to about 76% of the words. So this is a percentage of a total of 150 words that were presented. In a few minutes of speech, you're going to hear about 200 words. If you can understand 7 or 8 more of them, that is a huge benefit to understanding speech and noise, especially for older adults, because one thing that older adults are better at using is contextual cues. So if you can pick out a few extra words in a sentence, you can use your sort of accumulated knowledge to help understand what that word is. So this is actually hugely beneficial, and most importantly, we didn't see any improvement in the other groups. So we improved the ability to understand speech and noise with 6 months of music training. Next question is, how? What happened at the level of the brain? So here are the ERPs, what we talked about before. We have on the top the music group, the bottom the control group. Now the way an ERP is plotted, this large line represents when the word was presented. And we're looking at 1 second of brain processing. So there's 0, and then we have 800 milliseconds and then 1,000. So this is 1 second. I've averaged the two control groups. This is the video game group and the no contact, just to make things a little simpler. And the different colored lines on each of these plots represent the session, so pre, mid, and post. And then the first column is no noise, the second column is the quiet noise, and the third column is the loud noise. The first thing you'll notice sort of overall is the response to the word, this nice sort of evoked response here gets sort of squiggly as we add background noise. Again, that makes sense. Your brain can't really hear the word as well. Most importantly, though, what we found was that in all three conditions, this brain activity became more positive. Now, in the ERP world, we plot negative up, so getting more positive is down in this case, sort of a weird plotting history. But we saw that across all three conditions. And we didn't see any of it in the other groups. So starting from about 200 milliseconds onward, we saw this change in brain activity. And we found it over these electrodes, over frontal left regions of the scalp. So you might think, well, what brain regions are right underneath there? That's what we're measuring, right? But that's not the case. So the thing about electrical signals is they keep propagating. So you might measure something here that comes from over here, but if the electrical field is oriented in such a way that it's pointing there, then even though it's coming from here, you measure it here. The problem is with the EEG is that there's an infinite number of possible sources to any given scalp topography. So we have to use some models to sort of figure out where in the brain things are coming from. I'll tell you about that in just a sec, but just to support that, we also looked at the change in brain activity, compared it to the change in behavior, and the change in that brain activity that we saw was correlated to the amount of change in speech noise. So really they're related to each other. Now back to the brain. So we looked at this area, we ran one of these analyses, one called a local autoregressive average, and it told us there was 4 regions contributing to this area. So we looked at the left inferior frontal gyrus, the left middle temporal gyrus, the right parahippocampal gyrus, and the right cerebellum. Now, of course, these are pretty meaningless unless you know what these areas do. So what do these areas do? So the medial temporal gyrus and the parahippocampal gyrus are actually very close to each other, first of all. The medial temporal gyrus is right there. On this image, it would be right here, and then the parahippocampal gyrus there. So they're actually neighbors, even though in the two images they look kind of far away. These are areas that are part of your mental dictionary, or your mental lexicon. You hear a word, you got to look it up and figure out if I know that word, match it to understand what it is. The other 2 areas, the inferior frontal gyrus and the cerebellum, are both involved in planning speech, planning the movement of speech, not perceiving speech, but planning the production. And that sort of makes sense. We asked people to repeat the word aloud, so maybe the motor system was enhanced, but we didn't really train that, so it was, and their hearing improved, not their ability to produce the word. So we were a little confused by this, but it seemed to be motor systems, not auditory systems, that seem to be more enhanced. So hold that thought, and let's go to the MRI. So we also did an MRI task. Now, MRI is a little more complicated. You lie down, you go into this big tube, you have to stay very still while you're having your brain measured, because if you move, it blurs the image. Now, what is MRI? MRI is a way to measure brain function, brain structure. And the way it basically works is you go into that large tube, it's a giant magnet. So before you go in, if you were to do an MRI, you take all your clothes off, you get, it's like you're going through airport security, they make sure there's no metal on you, because if you can look up online if metal gets into the scanner, it boom, goes in, it can be very dangerous. So it's a very strong magnet. What it does is, if you imagine all the atoms in your brain are sort of in random orientations, any magnetic atom, so when you go in the scanner, they all orient in the line with the scanner, so they all focus in the magnetic line. And then, in the scanner, a radio frequency pulses them out of alignment, and then they move back into alignment. The rate at which they move back into alignment differs between different types of tissue. So if you're getting your bone MRI'd, the difference between the bone and the skin is what allows you to see the bone. If you're getting your brain MRI'd, the difference between white matter, gray matter, skull, cerebrospinal fluid, that's what allows you to see your brain. If we want to measure the function of the brain, what we're measuring is differences between blood that has lots of oxygen and blood that doesn't have any oxygen. So you're measuring a contrast between oxygenated and deoxygenated blood. And the idea is that if a brain region is more active, it's using more oxygen. So we can measure what brain regions are using the most oxygen when you're doing a task. And that's what fMRI is. What it's really good at is measuring where things are happening, but because we're measuring blood flow, it's really bad at measuring when things happen. So unlike EEG, where we saw changes that occurred on the sort of millisecond level, here we're talking about sort of changes that happen on the 5 or 10 second level. So we're just going to look for sort of areas of the brain that are active. Also, because it takes longer for it to build up, we did a slightly different test with complete sentences, and we didn't want people moving, so they made no motor responses. We had a forced choice, and they pressed a button. I'm going to play sample for you again. Again, they're in French, and they'll start out with the loud noise condition. So you hear background noise and then a full sentence. Here's a medium noise condition.
L'enfant dessine un cochon.
Hopefully the sentence was a little clearer that time. And then a no noise condition is a baseline.
L'enfant dessine un cochon.
After they'd hear a sentence, they'd see an image like this, and they'd have to press a button. For those of you that don't speak French, the sentence was l'enfant dessine un cochon, means the child draws a pig. So the correct answer would be number 1. We usually had a foil, so we put a picture of a pig that if they just heard one word, they might select that. And then a few other options to select. The important question is, what was improved? So these were the areas that we found improvements to: the medial frontal gyrus, superior middle temporal gyrus. Hey, we heard that one before. Supramarginal gyrus, middle frontal gyrus. I think we heard that one before as well. And the Rolandic sulcus. Again, these are all parts of the motor system. And there was no repetition in this, almost no motor movements. The movement was, boop, press a button, try to stay as still as possible. So we thought, that's strange, how come we're improving the motor system? So we did a little bit of research, as we're prone to do. And we found out that there is 2 major pathways which we hear. One works with the acoustic information, but the second works with the motor system. So the motor system is involved in trying to reverse engineer what you're hearing when you're listening to sound. Basically, your brain is simulating how your tongue would move, how your lips would move, how your larynx would move, to try and figure out what the person is saying. And basically, your brain sounds out the speech to try and aid in comprehension. And what studies have shown is that when you're doing speech and noise tasks, that if you look at which pathway, the auditory or acoustic pathway versus this motor pathway is more important, the motor pathway is much more important when doing speech and noise tasks. So we think is that music lessons aid the system because learning music requires mapping motor movements to specific sounds. So you're basically, musical training is connecting your auditory and motor systems and making that connection stronger. So we're connecting perception and production. So to summarize, 6 months of music lessons improved the ability to understand speech and noise, and we think that music training could be used to develop auditory rehabilitation programs for older adults. Overall, it suggests music training improves the ability to orient attention to critical components of the auditory code. We didn't see, I remember I talked about that passive condition, no benefits in the passive condition. So really we think it's to do with attentive listening and conscious listening. And it's about mapping attentional focus to that phonemic code. And so involvement of the motor system is critical if we're going to develop rehabilitation programs. You need people moving, you need them synchronizing their movements to sound, not just listening. So, let's change directions. The second part of my talk, I want to talk about how music perception changes with age. So, in the cognitive science literature, we know aging is associated with worse hearing. We talked about that a lot already, so it's pretty much universal. And in general, slower processing of information. There are benefits with aging. We see much better crystallized processing of information, so we have wisdom and knowledge, but sometimes things that require rapid processing are a little bit slower in older adults. Given that music is rapid, sometimes there's thousands of notes in a minute, so you're processing all this information very rapidly, it relies on hearing, we would predict that music perception abilities should decline in older adults, much like we would expect other hearing abilities would decline and other rapid cognitive processing tasks. But we also know that music enjoyment persists in older adults. People don't usually stop listening to music as they get older, and in fact, some people may have seen those wonderful videos of people with significant cognitive decline listening to music from their childhood, and they have moments of lucidity. So there's something, there's an asymmetry there. Is it going to decline, or are we going to see no decline? So we'll go on in that, and then let's split up what music perception is. So again, this is a room full of people who are musicians or musicologists. I'm going to divide music into two things. I'm going to divide it into tonality and rhythm. Don't throw your tomatoes yet. Just so we can talk about talk about a couple of different studies that I've done. So tonality is the hierarchical relationship between different notes. And we're going to look at how the brain responds to bad notes in a melody. And that's going to give us clues as how the brain processes the tonal structure of music, the relationship of notes. Rhythm is the temporal organization of notes over time into beats and things like that. And what we're going to look at is the strength of the neural entrainment to a beat. So let's start with tonality. And we did a study we wanted to look at the ability to detect bad notes in a melody and looked at brain responses. The nice thing is, you don't need to be a musician to detect bad notes. Anybody who's been exposed to music, listens to music, can tell you if there's a bad note in a melody. So we test anybody. So we test these are non-musicians, just healthy young adults, healthy older adults. So very little music training, but we're matched in terms of education, everything else except for age. The task looked like this. We played melodies for people, and there was two tasks. There was a pitch detection task where we asked people to actually tell us if they heard a bad note, and then a click detection task. And this gets back again to that idea of implicit versus explicit processing. We wanted to see what happens when you're processing a bad note when you're not actually listening to the melody. I'm not going to talk too much about the results from that, but that was what happened. So in the pitch detection task, you hear a melody like this. Then you'd be presented a screen like this. Was there any wrong notes? So that melody had no wrong notes. So we would select 4, but if you're not sure, you might have selected 1 if you were guessing or didn't know. The click detection task was like this. You heard the same melodies, but there was a very, very small, subtle click embedded into the melody. It kind of sounds like a static pop, like when you're plugging in a microphone or something. Very subtle, very hard to hear. So I'll play it, and there is a click, so see if you can hear it. So at the very end of the melody, there's a little pop. And we adjusted it so it was difficult for everybody to hear. So in that one, they would have responded, click, sure. And then here is an example of a note with a bad note in it. Bad note. Pretty obvious. You don't need to be a musician to hear that. So what did we find? First of all, the click detection task, older and younger adults did about as well. We actually also, we divided the types of bad notes into two types. One we call out of key, so we basically took the good note and just shifted it 1 semitone, so it's still a chromatic note but not part of the major scale that was used to construct the melody. And an out of two note which was shifted half of a semitone, so it became an illegal note. It's just not a note that's you would normally hear unless you were like bending a string or playing something that's not a fixed pitch instrument and you want to get there. More importantly, what happened in terms of being able to detect a bad note? In this task, the older adults outperformed the younger adults, did way better. So for the out of key note, the older adults had way higher accuracy. What we're looking at here also is an accuracy measure called hits minus false alarms, so you might wonder why it's low. The reason we do that is, let's say somebody came in and just said bad note, bad note, bad note, bad note, bad note, bad note, bad note. So if they would get 100% of the bad notes. So that would make their accuracy look really good, even though they weren't actually doing the task properly. If we subtract, so that's called a hit, when they successfully identify a bad note. If there's no bad note and they say there's a bad note, we call that a false alarm. So if they just press bad note, bad note, bad note, bad note, bad note, bad note, they would get 100% hits, 100% false alarms. We subtract the false alarms from the hits, their accuracy would be 0. And that's why we plot it this way, so that if they're making mistakes, we can standardize that. So the important thing is the older adults did better on this task, both for the out of key note and for the out of tune note. What happened to the level of the brain? So here we're looking at ERPs again. So here's our ERP. So there's, again, 1 second of processing. The bad note, or good note, in any case, was presented right here at the 0 line. The red line indicates our sort of good note. The blue line represents the out of tune or out of key note, depending on which one we're looking at. This column is the younger adults. This column is the older adults. What we're looking at is something called an ERAN here. And this is the automatic stage of processing here. What we have is this in key note in red, and the out of key note is in blue. And what I've highlighted is the difference between those two. And that difference we call an early right anterior negativity. It occurs sort of early, at around 150 milliseconds after the note starts. So basically your brain has already heard a bad note halfway through the note. It already knows that there's a bad note. The note isn't finished yet and you know it's a bad note. And it was evoked in all 4 groups. Now, in the condition where we had them respond to the bad note, we see another wave. And again, this gets back to that implicit versus explicit process. The ERAN is this automatic response. It doesn't matter if they're detecting a click or they're detecting the pitch. We see this response. The brain sort of says there's a bad note. If you're doing the click detection task, that's the end of it. Your brain says, I don't care. I'm doing something else right now. I don't want to hear about that. But if you're detecting the bad note, we see another wave, and this is called a P600. So same type of thing we're looking at here, same graph, in key notes in red, out of key or out of tune notes in blue, and what you see is when there's a bad note, there's this huge change in processing that occurs in the bad note compared to the good note, and again we highlight that in black, and we evoke that in all 4 groups. So the real question is, well, what happened in terms of brain activity? And we actually found the brain activity was larger in the younger adults. So despite the fact the older adults did the task better, the brain activity was larger in the younger adults. We also looked at the connection between the brain activity and the performance, and we found a significant relationship. But the important thing is that relationship was a bit weaker in the older adults. So we see the slope of the line, in both cases here, the black lines are the older adults, is a little bit shallower than the slope of the line for the younger adults, which is a little bit steeper. So what that tells us is that the region we focused on may not have captured everything that happened in the older adults. So we think was going on was a more distributed bit of brain activity. Older adults were utilizing other brain regions to accomplish the same task. So we saw overall this increased accuracy, but reduced ERAN and P600. So we think that it's due to sort of a more distributed neurophysiology, but they're performing the task the same way. Effectively, your ability to hear a bad note in a melody is preserved as you get older, and the way your brain does it changes a little bit. What about rhythm perception? So rhythmic entrainment is a core component of music perception. And again, like detecting a bad note, it's learned implicitly. So you don't need to be a musician to be able to clap to a beat. You can hear a beat, you can clap along. We wanted to look at how well people could how well their brains synchronized to different rhythms. Again, older, younger adults, generally matched except in terms of age. And we used a technique called frequency tagging. So again, with the EEG, but instead of looking at those averages, what we wanted to look at is the rate at which the brain was oscillating, different rates. And the neat thing is the brain entrains to rhythm. So if we play a metronome click, say you play a metronome click at 120 beats per minute. Now I like thinking in hertz, because that's the way brain scientists like to think. But we can convert that to hertz. 120 beats per minute, 2 beats per second, 2 hertz. Let's talk about hertz. So if we play a metronome click at 120 beats per minute, and then measure somebody's brain activity, we're going to get a 2 hertz oscillation. We play a 2 hertz sound, we're going to get a 2 hertz oscillation. Now, if you ask that person to mentally metricize that, so imagine, don't move, just imagine a march. So you're still hearing the same 2 hertz click, but you're going to sort of emphasize one of those beats. So boom, 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 boom. So you're imagining a march. So that stronger beat is now occurring 1 time a second, 60 beats a minute, or 1 hertz. And the neat thing is, we'll see a 1 hertz oscillation in the brain when that's happening. We ask people to metricize the same metronome click to a waltz. So now you have to subdivide into 3. strong, weak, weak, strong, weak, weak. But you're just imagining it. The stimulus doesn't change. So now we're going to see that 2 hertz oscillation. The 1 hertz oscillation will disappear because now you're not thinking in 2s, you're thinking in 3s, but we will see an emergence of a oscillation at 0.666666 hertz, which is 2 hertz divided by 3. So we can measure the strength of these neural oscillations to look at how well the brain entrains to rhythms in music. So what we wanted to do is look at how the brain entrains. So we designed a study where people would tap along to a rhythm for about 12 seconds and then rest for 48 seconds, so do nothing, but mentally maintain where the beat was in the rhythm. And then we could look at their brain oscillations to that rhythm and then look at how it relates to the stimulus and how we had them counting it. We had 2 types of rhythms, a syncopated and a non-syncopated rhythm at 2 different tempos, a slow and a fast. And in both cases, the beat the person was expected to tap to was in the slow condition at 1.25 hertz and the fast condition 2.5 hertz. So this is the non-syncopated version. Something like that. So the important thing here in the syncopated version is that there's acoustic energy at 1.25 hertz. There's a sound every 1.25 hertz. The syncopated condition sounds like this. I think I got that. The important thing here is that there is no acoustic energy at the beat. So the rhythm was designed in such a way that there would be no sound at that cycle. So if there's brain activity at that cycle, it means it's entirely being generated by the person's perception, not by the sound itself. So first let's look at tapping performance. Take this with a grain of salt. The study was not designed to assess tapping performance. It was designed to assess brain activity. But generally what we found is that all the people, so what we're looking at here is their time between taps. And we expect the time between taps to be hover around the same time because it's the same speed. Slower tempo at the top, faster at the bottom. And you can see almost all the participants were right around where the beat interval was at 800 milliseconds. For both the non-syncopated and the syncopated, some variability, of course, and each of these lines represents one participant. Some people sort of found a different place to tap. Which, the meter is subjective, so they found a different place. But there was no difference, basically. The important thing is no difference between older and younger adults here. Tapping, same in older and younger adults. Now let's get to the frequency tagging. So again, now we're looking, this is the brain activity. We've converted this to frequency information in a lot of graphs. There's our slow tempo, fast tempo. We have amplitude, this is the size of the response. And then these are the frequencies. So for the slow tempo, I said 1.25 hertz is our important rhythm. But if you double that, so we imagine the beat in duple time, you would get a rhythm here. And if you quadruple it, you get to there. So we see oscillations at all those rhythms for both the non-syncopated and syncopated. So this is where this is all mentally generated for this one because there's no acoustic energy at that frequency. And then the same thing for older adults. The amplitudes look a bit different, but again, the scale here is 0.1 to 0.2, very small scale. Statistically, no difference. So there was no effect of age on frequency tagging. Tapping performance was the same. Frequency tagging, the ERP results were the same. So it suggests rhythm processing is little impacted by age. So music perception seems to be relatively preserved as we get older. Some of the functional neurophysiology changes for tonality, but not for rhythm. Now, the really interesting about rhythm, and this is where we're going to tie back to the first studies. How do we process rhythm? Rhythm is processed in the motor system. When you're processing a rhythm, it's structures that are involved in the motor system that are engaged, and this is where we don't see any decline. So this is an area of strength. So the neural architecture that supports music perception could potentially be used as a scaffold to develop other rehabilitation programs. Now, what do I mean by this? Let's jump over to a condition called aphasia. Aphasia is a speech disorder. You have difficulty talking. Some people with aphasia maintain the ability to sing. So they can sing, but they can't talk. And there was a therapy developed where they reteach people with aphasia to talk by singing. They take an area of their neural strength, singing, and map talking onto it. How do they do it? They'll say, okay, we're gonna do conversations today. Say you're gonna say, hello, how are you? But we'll sing it. Hello, how are you? And they can sing it. And so it starts off, their conversations sound very strange because they're singing to you, but over time they learn to sort of reduce the singiness of it and make it sound more like natural speech, and that allows people with aphasia to regain the ability to talk. So potentially we could now use, we know that rhythm perception is preserved in older adults. We know that it relies on the motor system. We know that music training improves the motor system in terms of perceiving speech. And so we think that, again, these two pieces of knowledge can be used to design music-based forms of auditory rehabilitation. And the key features are that they need to integrate the auditory motor system with a focus on rhythm. They need to connect speech to music in order to scaffold impaired speech perception onto music perception. That's where I'm going to finish today. Thank you very much for all your attention, and I'm happy to take any questions.
As someone with two aging parents, it's you know, because I'm thinking, like, that's fascinating. I think about now the therapy side of it, like how can it actually be implemented? And, you know, it's so difficult with my parents to get them to do the simplest little things, you know. Is there an opportunity, or are you looking at how you can gamify this? You know, like the things that you're doing in the lab, you're getting people to show up. Is there some way we can intermix these types of things in their lives to get the benefits?
Yeah, so I mean, you saw like the music training we used was basically a video game. In the future, I think that's a really good idea because sort of a generation, sort of everybody who's sort of middle-aged and younger is very familiar with video games. Again, if we looked at the data from our video game study, people who are currently older are actually not that interested in gamification at this point. Probably would do better with an instructor, in a group, things like that. So we haven't thought too much about sort of, let's say, the engineering side of this, how we can actualize this at this point. More we're thinking of at this point, thinking of what features a music-based form of rehabilitation would need to have. And how that's implemented really can, I think, can be customized to the individual, right? So you might have some people that want to, you know, sing and be in a group and be in a choir. Maybe something like that would be beneficial. Somebody else, maybe more introverted, doesn't want to go out in public. Maybe they want to stay home and do work one-on-one with the teacher. Maybe they want to use a video game system. So again, I'm not sure if the mode of delivery is the critical thing here. I think really it's about trying to, is sort of identifying the key features, which we started to do, and finding ways that the people who want to engage this would engage it, right? So if they don't want to play a game, then saying play this video game, not going to be very useful, right? So we want to, that's the key, and that's individual differences. There's no solution for everybody, right? So that's one thing we have to think about is, you know, how we present something like this. And, you know, so there might be multiple ways of how we instantiate it, but focusing on what those key features might be in terms of what the music-based rehabilitation might look like.
I take my phone and I tune into a radio station, and I listen to it with my bad ear only. And after about 5 minutes, I can hear more clearly.
Yep.
But in the beginning, it's just like muffly, but it clears. As I just used the one earphone, and it does clear after about, you know, a couple of minutes.
Couple of minutes, yeah.
And the longer I listen with just the one ear, the clearer I can hear what's being said or played on the radio.
Yeah, so there's some neat, I mean, it's neat that you noticed that there is, it's not my research area, but there's people who study what we'll call rapid neuroplasticity. And there's things that happen in your auditory system very quickly. There's changes in brain responses that can be observed almost on a trial-by-trial basis. So you present a sound once, and the brain response the next time will be a little bit different. So it's possible that when you're listening, you're basically sort of priming the pump, if you will. It might be a way to think of it as it starts off difficult, your brain's sort of starting to tune in what frequencies are important here, what frequencies are not important, and again, you're attending to it, so you're putting that energy into identifying it, and eventually that rapid plasticity may engage, and that might be why that functions, that happens, and that experience, yeah?
Very interesting.
Thank you.
Is possible in person with Alzheimer?
That's a good question. I don't think so. Alzheimer's is pretty debilitating, and usually people with sort of significant cognitive decline aren't able to learn and perform music. There are people, I've seen videos, I haven't seen this in person, but I've seen videos of people with Alzheimer's that maintain, if they were musicians to begin with, they sometimes have a preserved ability to perform music. But what this is really aimed at is what I tend to call, let's say, normative hearing loss. So this isn't dealing with people with extreme clinical conditions or even extreme hearing loss for that matter. Again, this is all about the brain. So if you go to loud rock concerts and destroy all the hair cells in your ear, this is going to have no benefit for you at all, because if the hair cells aren't working, aren't sending a signal to the brain, then there's no signal to process. There's nothing to improve. So it's really based on sort of what I think this is helpful for is sort of that, everybody experiences some hearing loss as they get older. Some people experience sort of extreme clinical loss. A very few number of people experience nothing, but most people sort of, until they're very, very old, don't experience significant hearing loss. And so this is for them. It's for sort of that, to help give you a few extra years of good hearing as you get older, is the idea.
If I could ask maybe a small question.
Sure.
So some of the auditory perception is happening through motor processes, correct?
Yes.
In the first set of studies where you were training people to play piano, the motor processes would be different from the ones that would be mimicked if you were trying to hear speech sounds.
Right.
So if you were training people to speak, say, sounds from a language that they're newly learning, would that give them new, better perceptual abilities?
That's a great question, and I hope to answer that question in a couple of years when I finish the study that I'm just starting on that area. We're looking at, it's one question we've thought about is whether language training might be beneficial, and so I've just started a collaboration with a professor in linguistics, and we're going to look at whether language training can improve some cognitive abilities, and I'm going to throw a few hearing tests in there to test that idea. But it's certainly possible. It's a new auditory motor connection, and so I think it's possible. And we'll see. We'll let the data speak.
Interesting, fascinating. Can I ask, just follow up on one other?
Absolutely.
You talked earlier about how hearing loss is associated in aging with depression. What about the reverse? If people develop depression, does that have an impact on auditory capabilities?
That's a good question. I don't know offhand if there's a reported connection between that. Again, it's difficult determining direction of causality in these studies, right? Because we're not giving people depression, and we're not, okay, now you're going to be depressed. We're going to give you this drug to make you depressed and to see if your hearing gets worse, or we're going to, make your hearing bad and see if you get depressed. So it's epidemiological studies studying sort of over large numbers of people. To me, the explanation of hearing loss leading to depression makes more sense to me than depression leading to hearing loss. But if you can think of an explanation to why sort of biomechanically or biophysically that depression might, there could be I guess there could be a biochemical reason that if you're, whatever's causing depression also has some impact on auditory neurons, there could be an association there as well. But I'm not familiar with any sort of studies that argue that.
Interesting. I mean, I guess the thought that was coming to mind is with really profound depression, it can even make you physically lethargic.
Right.
So you might not be responding as much, and maybe the parts of the brain that would be trying to do the processing by way of mimicking the motor processes might
right.
be slowed down.
I guess the way I would think about that is that if it's in those situations with severe depression or any severe sort of disorder where you might see hearing loss, that if you fix the depression, does the hearing loss remain?
Right.
Right? And if it does, then clearly there's been some permanent change because of it. But if everything returns after fixing the depression or whatever other sort of mental health issue you want to talk about, then that suggests that it's sort of transiently related to that condition, but it's not going to permanently affect you down the road.
Interesting.
But again, I don't have data to support any of that. These are just thoughts.
Thank you. Very interesting talk. My question is whether you gather any information about the listening habits of the people that are involved in these studies. Those that have played rock and roll as opposed to those that only listen to Beethoven, or those that are from a culture where, in fact, the tonalities and there might be microtonal scales rather than the ones that you played for us tonight.
Yeah. So all the participants are, let's say, indoctrinated with Western music theory, right? And that's based, the only way to really avoid that at this point in history is to go find uncontacted tribes. Because even people who grow up in cultures where other musics are possible, or even in our culture where we have atonal music and things like that, and serial music, all it takes is passive exposure. So learning our Western major key musical system just requires exposure. So anybody who's heard Bob Marley is familiar with Western tonal music. Anybody who's heard the Beatles is familiar with Western tonal music. So, and they would respond like this. So the only people and there's people who are doing this, who are going to like the Amazon and bringing, computer rigs with them and hearing stuff and trying to figure out how people process music. And it's led to some very surprising results. Things like octave equivalence, and even that the octave is a consonant relationship is not consistent. There are people that don't find the octave a consonant relationship. But anybody who's indoctrinated with Western music, which is most of the world at this point, would view the octave as being a consonant relationship. So there's certainly an effect, but everybody tested here is, we'll say, Western music educated, or at least Western music exposed. In terms of the musicians, in the first study I talked about, we were not picky with style, we were just picky with training and time, that you had to be playing regularly and had to have some formal training. There was people there, we had people from the symphony, I had people from military marching bands, I had people who played in rock bands, I had folk singers, we had a little bit of everybody. So it was really, the idea was to try and generalize across music performance regardless of what your training background was. Yeah, so they're all, and yeah, so they're all familiar with the Western system, and that's.
I just want to know how the Grammy Foundation is assisting your research.
Oh, great question. The Grammy Foundation has scientific research grants. And they award, maybe this is useful for people in this room, every year the LOI is coming up. I believe it's in November at some point. They have grants to do research on music and like musical archiving projects. So I applied about 10 years ago at this point, and got some money from the Grammy Foundation to do the music training study that I talked about today.
Thank you so much.
Thank you for having me.